So we are starting our case presentation. A case is a 26-year-old female who presented with complaints of recurrent episodes of fever for the past 2 months, vomiting for the past 1 month, and abdominal pain for the past 2 weeks. Coming to history of presenting complaints. Patient was apparently asymptomatic 2 months back when she started experiencing recurrent episodes of low-grade fever. There was no diurnal variation of fever and it was not associated with chills, rigor, night sweats or rashes. It gets relieved on taking paracetamol. Patient also has complaints of vomiting since the past 1 month, which worsened in the past 2 weeks. It was non-projectile, non-bilious and non-blood-stained. She also had intermittent episodes of abdominal pain for the past 2 weeks, more in the right upper quadrant. It is colicky in nature and aggravates after food intake and relieves spontaneously. There was no radiation of pain. Coming to past history, she had history of hypertension for the past 4 years and hypothyroidism for the past 3 months. No history of diabetes, CAD, CVA, TBI, asthma or CLD. No history of any drug allergies or any surgeries in the past. There is no significant family history, and in personal history, she had history of snoring. There was no witness apneas or daytime somnolence. Her appetite was normal, bowel and bladder habits were normal, and no history of any addictions. In general examination, patient was conscious, cooperative and oriented to time, place and person. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. Her height was 157 cm and weight 102 kg and BMI 41.38 kg per meter square. Her vitals were stable. Airway examination showed no loose tooth or artificial dentures. Her temporomandible joint was mobile. Mouth opening was 3 finger breadth. Mallampati classification was class 3. Thyroidal distance was 2 finger breadth. Sternomental distance of 10 centimeter and neck circumference of 45 centimeter. There's a restriction in extension terminally. Upper lip bite test was class 2. Her stop bank score is 4. All systems were within normal limits. Investigations were all normal and USG was suggestive of acute calculus cholecystitis. Summary, it was a 26-year-old female with morbid obesity who presented with recurrent episodes of vomiting, fever and abdominal pain. On examination, patient is conscious, oriented with stable vital signs. Airway examination suggestive of difficult airway. Abdominal examination revealed tenderness in right hypochondrium. Patient is diagnosed to have acute calculus cholecystitis and is planned for lap cholecystectomy. So our case is a patient with morbid obesity and difficult airway diagnosed with acute calculus cholecystitis and is posted for laparoscopic cholecystectomy.
So here is a patient with morbid obesity with difficult airway for laparoscopic surgeries. What are the concerns regarding us?
This is a patient with morbid obesity. Her BMI is 40.38, which makes her morbidly obese or class 3 of obesity. And an airway examination also showed a difficult airway.
So the concerns are due to difficult airway, obesity and laparoscopic cholecystectomy, problems of laparoscopy. So we are skipping the problems of laparoscopy in this section since it's only a short case. So how do you classify obesity?
Obesity is classified based on the BMI. Patient will be underweight when BMI is less than 18.5, normal weight when BMI is 18.5 to 24.9, and overweight 25 to 29.9, and class 1 obesity 30 to 34.9, and class 2 35 to 39.9. Class 3 is morbid obesity where BMI is more than or equal to 40, and super obesity where BMI is more than or equal to 50.
So what is the term called total body weight? What are the components of total body weight?
So total body weight is the weight which the person actually weighs. It consists of the fat, muscle mass, bones, the fluid. The total weight that we get when we measure the patient is the total body weight.
What is lean body weight?
Lean body weight is the body weight of the patient excluding all the fat content.
So, and what is ideal body weight?
Ideal body weight is the weight of the patient adjusted to the lean mass of the patient, and it is specific for it is adjusted for age and gender of the patient. Approximately, we can calculate it as height height minus 100 in males and 105 in females.
What is the relevance of this understanding body weight in our specialty?
The drug we have given is depends upon total body weight, lean body weight and ideal body weight. The choline we given depends upon total body weight, and most of the induction agents like propofol, ethomidate, thiopentone, the induction dose depends upon lean body weight, and the maintenance that depends upon total body weight.
What is regarding ideal body weight?
Adrenaline, noradrenaline, vasopressors, all these are depends upon ideal body weight, the
We
dose.
used to give adrenaline, noradrenaline and other vasopressors depending upon the ideal body weight. That's the only situation where we need to know the ideal body weight. The rest just depends upon the total body weight and the lean body weight.
So basically it depends on whether the drugs are lipophilic or hydrophilic. What will be the case in lipophilic drugs? Lipophilic drugs.
Lipophilic, since these patients have a more fat content in their body, so lipophilic drugs will have an increased volume of distribution.
Yeah, so just give me an example. Induction agent.
Example, propofol.
So what happens for propofol?
So we have to give based on the lean body weight. Induction dose is based on the lean body weight for propofol, and maintenance dose is based on total body weight.
So initially the drug, the amount of drug you have to give will be quite large.
Yes.
But the maintenance dose can be decreased.
Yes. Yes.
And what about muscle relaxants?
Scoline we have to give based on total body weight. Other non-depolarizing we give based on lean body weight.
You mentioned some formula for calculating this ideal body weight, right? Do you have any other formulas? We have tables.
We have a formula for lean body weight. It's a Jamshedeti formula is the one that we use for calculating lean body weight. That's the most accurate one for a patient with morbid obesity.
And I think you have formulas like Hams and Devins.
Yes.
Those are just names. You have tables which can be used for calculating the ideal body weight.
Yes.
What weight do you use for ventilatory purposes?
We use ideal body weight for setting the tidal volume.
Okay. So in obesity, you expect quite a lot of physiological changes other than compared to a normal population. Let's take it system by system. What about respiratory system? What are the changes in obesity you find?
All the volumes in the respiratory system will decrease. Tidal volume, functional residual capacity, residual volume, total lung capacity, all these volumes will decrease, and the respiratory rate will increase. And as the patient has more oxygen demand, the minute ventilation will increase. And the patient is more prone for asthma, and the work of breathing will increase as the chest complaints will be reduced, and there may be increased in intra-abdominal pressure. So the work of breathing will be increased.
You mentioned asthma. Asthma, I think, has a different pathology.
Yes.
Let's leave that out. So what is its implication during anesthesia? The changes in respiratory volumes and capacities.
Especially because the FRC and expiratory reserve volumes are reduced, we have to adequately pre-oxygenate these patients. These patients are more prone to desaturations. Also, since their chest wall compliance is reduced, they are more prone to atelectasis in the more post-op period.
Let's say in case we have to take an ABG in this case, what are you likely to find in an obese patient like this?
Sorry, sir, I didn't get it.
If you have to take an ABG, arterial blood gas analysis, on Romer, in this patient, what are you likely to find?
Metabolic acidosis.
More chance of hypoxia and increased hypercapnia.
Okay. There might be hypoxia as well as hypercarbia. And let's come to the cardiovascular system. What are the changes we expect in the cardiovascular system?
The total blood volume will be increased and the cardiac output also increases, but it depends only on the stroke volume, not on the heart rate. And there will be increased left ventricular mass formation, and that may result in increased pressure and volume overload that results in eccentric and concentric hypertrophy of the patient.
So, how will it manifest when you investigate the patient? ECG, echo.
ECG, there might be changes of left ventricular hypertrophy. Also, they might be more prone to arrhythmias, and there might be left axis deviation in these patients.
Any idea what arrhythmia specifically?
More atrial fibrillation is most common in obesity.
Yeah, as well as ventricular tachycardias. And what about echo?
Echo, there might be concentric LVH, and they might also have pulmonary artery hypertensions.
Why?
And
Why pulmonary artery hypertension?
Increased pressure in the left ventricle. So there may be chance of backward pressure and causing pulmonary arterial hypertension.
also in the respiratory system changes can cause pulmonary artery hypertension in this patient.
Yeah, a mixture of factors. What do these factors? How do they play out during your giving anesthesia? Means how will you manage these changes during anesthesia?
They have increased cardiac output, and they are more. They can be congestive cardiac failure is easily precipitated in obese patients. So we have to be careful while giving our anesthesia. We have to give judicious fluid administration.
What is OSA? Define.
OSA is a sleep disordered breathing syndrome with apnea-hypopnea index more than 5, where apnea is the complete cessation of respiration for more than 10 seconds, and hypopnea is cessation of airflow of more than 50% for more than 10%, more than 50% for 10 seconds. Which can lead to saturation fall of 3 to 4%, and some of this apnea and hypopnea is apnea-hypopnea index.
How do you screen OSA?
OSA can be screened with stop bank score, in which the S stands for snoring history and T for tiredness history, O for observed apnea, P for any history of hypertension or medications, B for BMI more than 35, age more than 50, neck circumference more than 40, and gender male.
What's the reason of pulmonary hypertension in obese patients? Since OSA is there, what are the dreaded indicators of postoperative intraop and postoperative complication? That is history of OSA and obesity hypoventilation syndrome. So these two can contribute to
Can cause
hypercarbia and hypoxia. These can contribute to pulmonary artery hypertension. Chronic hypoxia and chronic hypercarbia can contribute to pulmonary artery hypertension. What else? As you said, there is a chance of, what is the chance of occurrence of DVT, deep vein thrombosis?
It is 10 times more in obese patients compared to normal population.
Yeah.
This is because they can have hypoxia and hypercapnia. This causes polycythemia in this patient, which increases the blood viscosity and thus predisposes to varicose veins and DVTs.
For stasis and deep vein thrombosis is more in obese patients. So what are the general GIT, gastrointestinal manifestation of obesity?
They can have increased gastroesophageal reflex, so they might be more prone to
Is it
aspiration.
obesity per se will not cause increased gastroesophageal reflex, but what else? The incidence of hiatus hernia and
Reflex esophagitis.
reflex esophagitis is more, so it can coexist with obesity. So all obese patients are not having hiatus hernia and gastroesophageal reflexes. They should be considered as normal patients. Okay. Then what are the others? What is the significance of hiatus hernia and gastroesophageal reflexes associated with the obesity? What is our importance?
The main problem is while induction, we might have to choose a rapid sequence induction if hiatus hernia is present and they are more prone and reflex esophagitis is present.
So that is called physiological
Difficult air.
difficult airway. So obesity and difficult airway associated with the physiological difficult airway too. That this patient is having hiatus hernia and reflex esophagitis. It is called. Okay. Then what else? What else? What else in GIT?
Other organs of the gastrointestinal tract like liver can be affected. They are more prone to non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, cholelithiasis and all.
How will you reduce the morbidity? How will you preoperatively, how will you counsel the patient regarding that is what diet will you advised? What diet? What kind of diet? A liver shrinking diet can be advised preoperatively in case of a morbid obese patient. What is less than 1,000 calories per day? Advised to take less than 1,000 calories. So the weight reduction, you should also advise regarding actually the surgeon should advise the weight reduction strategy. Okay, then what else? What else? So what about central nervous system and obesity?
Central nervous system, again due to polycythemia and increased viscosity, they might be more prone to cerebrovascular accidents.
Like stroke and all. What about kidney?
They increased chance of AKIs.
Intraoperative and postoperative
and fluid
AK,
shifts.
there is an increased chance of AK, increased incidence of deep vein thrombosis. So what are your anesthetic concerns in obesity? How will you, anesthetic concerns? These are the anesthetic concerns. So coming to what are the other concerns to keep the dignity of the patient? So coming from that onwards, how will you preoperative counseling and preparation briefly discuss?
So in the preoperative period, we have to adequately pre-medicate the patient. We have to give a proton pump inhibitor. We give pantoprazole 40 mg in the night before and on day of the surgery. Also a prokinetic like metoclopramide 10 mg can be given the night before and on the day of the surgery.
So how will you keep the dignity of the patient going?
We have to make sure that OT gowns of adequate sizes are available. The rooms and tables which can hold the patient's weight is available, and mobilization difficulties might be there for this patient. So we have to tackle all that.
So encourage the patient to give adequate sized clothes and OT dresses all. What about the table size?
Table size should be such that it can accommodate the weight of the patient. We have to know beforehand the maximum weight our operation
Okay.
theatre can hold.
What about the shifting trolley and all?
All of this should be such,
Yes.
should accommodate the patient. If needed, larger size trolleys should be taken to shift the patient.
So briefly discuss what are the anesthetic problems, what are the what are our problem, we are going to face what all problems.
So, general problems in obesity will be these people have difficulty in mobilization, difficulty in obtaining an IV access might be there. There will be difficulty in our cannulation of arterial line and central lines. Also, BP cuff of adequate size might not be available. The positioning might be difficult in these patients. Also, these patients are more prone to pressure
Shifting,
sores.
positioning and all, difficulty to get a peripheral line, and also difficulty to do the central venous cannulation and arterial line if needed. Will you advise routine arterial cannulation?
If we can measure BP adequately with the cuff available, then we need not go with adequate intra-arterial
So
BP recording.
what are the sides you prefer?
Size should be such that the width of the cuff is at least 40% of the arm circumference, arm length, and length of the cuff should be 80%. And if this is not available, we can also try the cuff in the trying the cuff in the forearm. If all of this not work,
Yes, it is
only we need-
advised to keep the BP cuff in the forearm. We can also apply in the forearm too. What is the disadvantage of applying the BP cuff over the forearm?
then we usually
Just
keep
like,
it our
just like the tourniquet application, just like so forearm we cannot apply a tourniquet completely occlude the artery. So that's what it is advised to give a forearm BP cuff also if the arm BP cuff is not working properly. If it's not working in either way, we can select a direct arterial blood pressure. So what is the role of ultrasound in obesity?
Ultrasound might be needed for since these people have difficulty in our cannulation and IV access. We can use an ultrasound for getting a vascular access. Also for our intra-arterial BP monitoring, we can use an ultrasound. And also for CVL. In case of a difficult airway, we can use an ultrasound to identify our cricothyroid membrane, and also airway blocks can be given by ultrasound.
As Madam rightly mentioned, the dignity of the patient should be maintained. So, never make derogatory comments about the patient's size, even unknowingly. So we have a 26-year-old lady who is posted for laparoscopic cholecystectomy. How will you proceed with the case? What is your anesthesia plan for this patient? How will you talk to the patient? How will you preoperatively prepare the patient?
Yes, so since this is a morbidly obese patient with a difficult airway, a plan of anesthesia is general anesthesia with awake fiber optic intubation. So preoperatively, while seeing the patient, we'll counsel the patient and tell him how we will be going with the case. Also, we'll make sure that the patient will be cooperative on the day of the surgery. And we'll give a low dose of anxiolytic on pre-op day. 0.25 mg of alprazolam will be given. Then on the day.
Why do you decide to go in for a awake fiber optic intubation?
This is a obese patient with difficult airway, and in our institution, most difficult airways we go ahead with awake fiber optic intubation.
Okay. Yeah, please go ahead.
So on the day of the surgery, first we will prepare our OT. We'll make sure that the OT table can hold the patient. We'll also keep all our anesthetic equipments ready. Our difficult airway cart will be ready, which includes all our equipments like laryngoscope, various sizes of ET tubes, both flexometallic and also supraglottic airway device. Then our airway equipments like bougies, stillets, nasopharyngeal and oropharyngeal airways, video
Yes,
laryngoscope,
okay, fast.
video laryngoscopes and fiber optic, and also our ePhona kit will be kept ready, and we'll also calculate the total dose of lignocaine that can be given for the patient while administrating airway anesthesia. Then once the patient comes, we'll attach all the pre-induction monitors. Then we'll give a low dose of sedation before going ahead with our airway anesthesia, and also an anti-sialagogue like glycopyrrolate. Then we will keep nasal pledgets soaked in 2% lignocaine in the nasal cavity to anesthetize the branches of the trigeminal nerve, and then and 10% lignocaine spray will be instilled in the oropharynx and the larynx to anesthetize the superior laryngeal nerve and the glossopharyngeal nerve, and we will introduce the tube via the nose, and we'll use the spray as you go technique with 2% lignocaine to anesthetize our superior laryngeal nerve. And we'll do once the tube is in position, we will administer neuromuscular blockade and our induction agents and neuromuscular blockade, and go ahead with the surgery.
How do you confirm the position of the tube?
We can confirm with continuous waveform in the ETCO2 and by direct visualization of the vocal cord.
Okay, now you have intubated the patient. How will you maintain anesthesia?
We are going to maintain our anesthesia with neuromuscular blocking drugs guided by the neuromuscular monitor, and with volatile agents, sevoflurane will be kept. And
what would be your preferred volatile agent? Is it desflurane? Is it sevoflurane? If so, any reason?
We will keep sevoflurane as it.
Is there any advantage for desflurane over sevoflurane in an obese patient?
Sevoflurane and desflurane both have low blood gas partition coefficient. So
Which has lower coefficient?
desflurane.
Desflurane, it's 0.45. Sevoflurane has 0.65. So awakening would be better, easier with desflurane. Go on.
Then we will give our muscle relaxant based on the neuromuscular blocking agents, and once they also make sure that the patient receives adequate analgesia. Then once the case is over, we will go ahead with extubation only when the patient is fully awake with intact airway reflexes, and with complete reversal of the neuromuscular blocking agent with the reversal of choice.
Then what else? Address pain also. How will you regarding postoperative oxygenation, postoperative oxygen therapy? How will you decide whether the patient may need postoperative oxygen therapy for and the hours of postoperative oxygen therapy?
It varies from patient to patient. Oxygen can be given via face mask.
Or will you use other measures?
We can also use HFNO or CPAP.
Other than the patient, whether the patient was on CPAP or BiPAP machine, use the CPAP and BiPAP machine during the postoperative period also. Otherwise, you will have to oxygenate the patient at least for 6 to 12 hours time. So then what about the sedation? So avoid sedative analgesics as far as possible. NSAIDs are advised, and patient controlled analgesia can also be given, and you can infiltrate the field with the what else? Local anesthetic agents. So the policy is to avoid sedative agents as for pain relief during the postoperative period in order to prevent postoperative hypoventilation. Okay, then how will you shift the patient from OT to the postoperative room? Fully awake,
fully awake with all the airway reflexes intact.
Yes, what else with the, if,
We can use a neuromuscular monitor
yeah.
to guide our.
Then what else? You can keep
use
a
a gel-
nasal airway, lubricated nasal airway during the immediate post-operative period. Any other to say? So the patient should be monitored for the next 12 hours, preferably in an ICU and at least in high dependency unit. So thank you all. Anything to ask?
In conclusion, can I say, we didn't, of course, could not go into the details of the DAS, difficult airway, this thing. Of course, part of it was discussed during the first case discussion, so in conclusion, let me say, obesity is an increasing problem, so we will be needing to administer anesthesia to more and more people with obesity. So we like to be well versed with two aspects of the thing, obesity per se, as well as managing a difficult airway. And you have something called as Obesity Surgery Mortality Stratification Index, MSOR score. I'm sorry, OSMR score, which is a 5-point validated system. It's used mainly in bariatric surgery. And previously, we used to think that in obese patients, you used to prefer elective ventilation post-operatively. But nowadays, again, the number of cases are increasing, the time taken for surgeries are shorter. So your plan has probably shifted from elective ventilation post-operatively to getting the patient awake and extubating the patient, but under ideal conditions, as we have already mentioned. Thank you.
Thank you. Thank you, ma'am.
Thank you for this wonderful session.